And it also seems like people here like each other.
Yeah. Yeah, I'm actually, when you say that, I think that's one big thing, that this is a small area, and if we have 100 people working here, working crisscross with each other, so people know also each other quite personally, you know. They can become friends and talk each other about other things also than work, and I think that's makes it easy for us to work in the way we work.
I ended up spending 2 weeks in northern Finland and became friendly with many of their clinicians. While talking off camera, I learned that several, to my surprise, had little experience working in a non-open dialogue system, to the degree that many appeared to underestimate the international significance of what they were doing. So your whole professional experience has been in this open dialogue system?
Yes, but I have a experience on meeting in a different area.
A conference?
No, like a patient that has gone to a different precinct.
Yeah.
And
a different area outside of your regular work area?
Yeah. And because we are outpatient clinic, that we treated him at home, but when he goes to another place, he goes to hospital, and we go to meeting there to
So you went there?
Yeah.
How was that?
I didn't like it.
What was it like?
There was a nurse and a doctor from that hospital, and us 2 nurses and the patient. And
so the 2 nurses from your system here?
Yeah. And we discussed with the patient and the nurses. We reflect.
Well, you did open dialogue.
Yeah, and try to speak openly on what we have done and what we think of situation and so on. But during the meeting, the doctor just listened, and when he had heard enough, she said, "Okay, thank you, I've heard enough," and goes away.
Didn't say anything?
No.
So didn't do open dialogue?
A couple of questions, but she doesn't participate on the dialogue.
Was that strange for you?
Yeah. And I said, okay, you go.
And you talked about this with the other nurse from your system here?
Yeah. We thought, when we talked afterwards, that with another nurse, that when the doctor goes away and said that, okay, that's enough for him, and left, I felt that, and she felt that, and what we were there about.
I was very curious how clinicians in Western Lapland approached the subject of neuroleptics, that is, antipsychotic medication. From what I have observed and studied, the use or non-use of neuroleptics is probably the most important factor correlated with recovery from psychosis. But before the essentials of the Finns' relationship to medication came to light, I found it important to explore some background, not just on neuroleptics, but on the Finns' conception of the very meaning of psychosis.
So most places
in the world, when they have a person with psychosis, they put them on very heavy medication immediately.
Is that like all over the world or just in the western part?
It's definitely in the western part of the world, but it's shifting to all over the world. And there is research showing that people with psychosis do better in
third world country.
What they did is they compared schizophrenia outcomes in poor countries of the world, specifically India, Nigeria, and Colombia, to rich countries, U.S. and other European countries, quote, the developed countries. Developing versus developed. Now, in each study, they found that outcomes at the end of 2 and 5 years, one was a 2-year, one was a 5-year study, were much, much better in the poor countries of the world, especially in India and Nigeria, by the way. Okay? And it was so dramatic, they said that living in a developed country is, quote, a strong predictor that you'll never fully recover from a psychotic or schizophrenic break.
All of us would have psychotic problems. It's an answer to a very difficult life situation. And when I face with a situation which is very stressful for me, so I can start to hear voices, for instance. And what happens in those voices or those experiences that I have, they can include something that previously has happened in my life.
We have to listen. We really have to listen and let them talk what has happened. And we can't know. Maybe some stories are so
Crazy.
maybe crazy. What is the right word?
We have to ask more about hallucination, and we have to ask more and try to understand what has happened. We don't say that you can't
That is,
speak
we
hallucinations.
we have no right to say that that is impossible. Because we really don't know.
Yeah. Yes,
It's not only that we are talking that we have an open dialogue system, but we dialogue have to really be open.
So one of the things they hypothesized, the WHO researchers, is, well, maybe what the difference is that people in the poor countries are better at taking antipsychotic medications. They live in a different environment where they follow doctors' orders better, and so they looked at medication usage. So the hypothesis was more medication usage would be associated with better outcomes. And they're hypothesizing that the meds should alter the long-term course of schizophrenia or psychosis. It's a valid hypothesis. That's what you'd expect drugs to do, if you're going to find them useful, is to alter the course. But what did they find? They found that in the poor countries of the world, only 16% of the people were regularly maintaining on antipsychotic medications. Whereas, of course, that's the standard of care in the developed countries. So here in this study, we found good long-term outcomes, much higher recovery rates associated with not maintaining people on medications.
Very seldom, very seldom I've been prescribing antipsychotic medicine. Usually,
What's the reason for so seldom prescribing it?
well, I don't actually. I think I prescribe very seldom any medication, so that's one point. That's one point.
In the first meeting, it's very non-understandable. I cannot understand what does it mean. I'm very confused. But later on, step by step, I start to realize that actually she is speaking of something that has happened in her life, and this may be the first time ever it become possible to have some words of those experiences. It's in a way a kind of metaphorical way to speak of things that beforehand did not have any words to speak about.
Psychotic meaning making is meaning making, and I want to have dialogue around meaning making, and I don't think we should medicate psychotic meaning making.
Oh, by the way, the WHO investigators eventually then did like a 25-year follow-up study of the patients in the poor countries, and it's really remarkable. I don't remember the statistics exactly, but somewhere between roughly 70% of the patients in that initial cohort of schizophrenia patients diagnosed in India and Nigeria, diagnosed as schizophrenic by Western doctors, not local doctors, so by Western standards, 20, 25 years later were working, asymptomatic. They just weren't schizophrenic anymore. They weren't psychotic anymore.
And for that reason, it's very important, actually extremely important for us to take it seriously, to start to listen what are her words, and step by step she perhaps have more and more words to her experience.
There's some kind of dilemma in your life and in your emotional life, and when you start to work with that dilemma, the symptoms can go away as well.
I learned during my time in Western Lapland that open dialogue practitioners view the concept of psychosis very differently from how most people view it in the United States. In America, psychosis is generally viewed as a problem residing in a particular individual's brain, which is why treatment so often involves pulling people out of their regular lives, hospitalizing them, and giving them brain-altering medications. In Western Lapland, however, they conceptualize psychosis as a problem arising in the space between individuals. That is, a problem occurring within relationships. Thus, their treatment seeks to engage social networks, rebuild relationships, and, if at all possible, avoid putting people through the alienating and stigmatizing experience of hospitalization. Why do you prefer to not put people in the hospital?
If the whole psychosis or situation goes over without coming to hospital,
So if they're able to work it through without
Yes.
going to the hospital.
yes, it's much better for the patient and family. They don't have history of mental hospital.
I remember one family in early 90s that they had a son about 25, 26 years old, and first he came into a hospital for some days.
Most of the times that need to be in hospital is because they need shelter or place to be, that it's safe enough to the patient, that he don't or she kill herself or is so psychotic that needs a safe place to be.
Another big reason, if someone hasn't been sleeping, let's say for a week, and they need a place where to kind of feel safe. So we can create those circumstances to their homes as well, if we do the cooperation and work together with the family.
And afterwards we asked the family what they think. They said that it was very hard when their son was in the hospital, and also that it was very hard to treat him at home, but it was much more easier at home.
So
Because-
you can work out those kind of issues in their home.
Yeah, and we can go there every day. We can be there, let's say we can have a treatment meeting, and then one nurse can stay there during the evening shift.
Like all night long?
Yeah,
With the
with the
patient?
family.
With
Yeah,
the family in the
Yeah.
home.
yeah.
And they said that it was wrong decision to come into the hospital at all.
So that just avoids the need for hospitalization then?
Yeah. And when we are home, there are more possibilities to have the conversations about the situation.
Very often these relatives comes to help. For family. But it's very typical then if we talk about adolescents and see or he has psychotic symptoms and see or he has parents. It's very typical that parents live on sick leave and they can support at home, and we meet for instance every day during these
First
two
days.
weeks, first days.
Always when we are treating at home, I think it's very important to have treatment meetings every day in the beginning and continue as long as needed.
Although I would ideally prefer a mental health system for psychosis that avoids neuroleptics entirely, the Finnish open dialogue clinicians employ a selective use of the medication model that comes closer to my ideal than any major program I've seen in the United States. For that reason, I found their point of view riveting, and in many cases, based on such common sense, that I wondered why it wasn't being utilized more widely in the Western world.
Now I ask about your documentary. When it comes out, what it is?
I'm not sure yet.
Okay,
I don't know.
you're just doing...
I'm making the movie first to show people in the world that there are better treatments than the conventional treatments.
So, here in the United States, where we've really embraced the drugs for life form of care, we see a explosion in the number of people, quote, disabled by mental illness. And we see all these other problems in terms of people dying early, etc., and low employment rates, decreasing employment rates. And here where they've used this drugs in a selective manner, what do they find? The exact opposite. So what should we do? Obviously we should go to, which is what you're going to do, we should go to Western Lapland if they'll have us and try to figure out what they're doing and emulate it.
Quite many people, psychotic people who come to us, they get some kind of medication. But it's for a short period of time to get over the worst, and then we discuss it all the time. So I think it's more of a minimizing the medication.
And which type of medication are you talking about?
Well, I'm not expert in those, but not so much about, neuroleptics, but more of a, sleeping pills or some anxiolytics.
We used it during the first week because the situation when they call us, so we will see them in the first 24 hours. And the situation is usually so that a person hasn't been sleeping for a week or two.
It's always here that we just consider as how many tablets we give. We don't prescribe a box of tablets, but we think maybe for 1 or 2 days use 2 or 4 tablets.
So that's the most common that they use in a short term, just 4 or 5 days or so, to get sleep and so. But in some cases they can use neuroleptics, but it's also a short term and in small doses.
In the beginning of the treatment, we have to, it's my opinion, have to avoid neuroleptic medication, but then if it's needed.
In any, let's say in 1 year, of all the patients that you see that have psychotic issues, what percentage get put on neuroleptic medication?
About 30.
30%.
Yes.
So 70% don't ever get neuroleptic
Yes.
medication.
Sometimes there are situations that patient need medication, also neuroleptic medication. There can be so kind of situations.
Here's a question I have.
Mm-hmm.
We were upstairs in that staff room,
Mm-hmm.
and I was playing with a pen. Did you see that?
No?
Well, I was playing with this really nice pen. I said, someone left their really nice pen here.
Mm-hmm.
And then I turned it over and it said Seroquel.
Yeah.
So I thought, it's even invaded this place.
Yeah.
And then I see when people are using the mouse pad,
Mhm.
it says,
Risperdal.
yeah, Effexor.
Yeah. But how we talk about that medication, and we have to be careful that those doses are appropriate, that there are no side effects.
Well, of course they come here as well to talk about the medication to doctors.
They do.
Yeah, and they bring good food many times and pancakes and stuff. And also we are going to have a day for staff next autumn, and so we have invited person from the drug company to come and tell about Seroquel, and then they are going to pay our lunch.
How do you feel about that?
It's okay for me because we are just listening them.
Is that it though?
Yeah.
It's quite usual for us to discuss a lot about medication. also with the psychiatrists when they're prescribing medication to some patients, then I would quite often ask, why do you prescribe this? What do you hope would happen? Would there be another?
And you say this right in front of the,
Yeah.
the client.
Yeah, so I think it's fair,
Yes.
just fair to say what our prejudices are and
What our thoughts are in front of the client.
yeah.
Well, actually, Birgitta, she's our doctor
Yeah.
in polyclinic, and she said that she's not going to call them. She doesn't do that.
Right.
So, but one of our nurses went to the educational days, and she asked because we said okay because we get a free lunch.
Right.
So take it.
I remember 2 patients I prescribed and tried to tell how you had to take this medication, but they never do that, and they are quite well.
So you prescribe. So there are even
Yes,
cases where you
yes,
prescribe the medication,
Yes, and
they don't even take
tried,
it.
yes, and tried to tell them that they had to take it.
And they didn't.
Yes, they didn't, and they are getting well.
Anyway,
Anyway.
against your advice.
Yes.
I wonder this.
Mm.
If you feel a patient needs neuroleptic medication later in the treatment,
Mm.
do you consider that a failure?
No. No.
There are so many other ways to help. There are so useful ways which have, I think, improves the agency of people much more than medication.
It seems to me if a person needs neuroleptics, it means they did not recover, right?
Yes, but I have also some kind of experiences that the patient have got neuroleptic medication later, but she or he needed it some months, 1-2 years, only a small dose, and after that she didn't need it.
I could bring up the idea as an option, as something we could have dialogue about around. Think about possible advantages, possible disadvantage, possible effects, possible side effects. But if I find a lot of other ways to work there, so I don't even have to bring this option